Bismillahirrahmanirrahim. Good evening, everyone. We start, inshallah, again. I wish that you enjoy today's cases, and we try to concentrate and focus in the exam. If there is any questions related to the exam. So, okay, what do you think about this case? This chest radiograph of this patient? How do you describe it? Frontal chest radiograph. So, anyone want to join us in the chat or in voice? Maybe you can see that there is yes. At least there is in the left side, mid zone, lower zone. There is opacity, yeah, and this opacity, it look like alveolar, more alveolar opacity, yeah. I understand that there is maybe like tubular appearance is not very obvious, but in this case, I think you will go in the management that you need CT, or maybe you check if this patient did high resolution CT. So let's shift to the CT and see how it look like. So this is the first cut of CT, which is selected images. Then maybe I will focus now, or I will stay in this image. How we describe it? Yes, 130. Okay, so there is a cluster of tubular opacities consolidation in the left lower loop and finger in glove appearance. So maybe due to mucoid impaction, maybe. So this is what is called allergic bronchopulmonary aspergillosis. So this is the first possibility. Okay, and it is like bronchocele appearance, so tubular opacities with cylindrical. So what do you think about this one? Yeah, there is again central bronchocele or central tubular opacities in the left upper loop and right upper and lower loop. Maybe we can confirm by CT again. In the X-ray, definitely that is not the best way to demonstrate, but you can see that finger in glove sign is very obvious here. And always you should describe, to not miss any marks, the type of bronchiectasis. So there is bronchiectasis, right? And it's better to mention is a central bronchiectasis and which loop is predominantly affected. And maybe if there is any tree in bud appearance, if there is any tree in bud appearance, also is nice to mention and to describe that there is transbronchial spread, yes or not. or endobronchial infiltration or infection. So this is the most important tips when you describe it in the long exam or in the description in the oral core exam, whatever. You should focus in this descriptive terms. So bronchiectasis, bronchocele, mucoid impaction, and the type of bronchiectasis, yes, and finger in glove sign, endobronchial spread, exactly. Huda, thank you. So allergic bronchopulmonary aspergillosis, which is type of hypersensitivity reaction, typically happen in asthmatic patients, you know, on this, or patient with cystic fibrosis. And you know that finger in glove sign is the best or the typical appearance for this. They like to mention something called fleeting alveolar infiltration. Fleeting, like migrating, that it appear in one X-ray in chest radiograph. Then after, for example, 2 weeks or 3 weeks, they disappear and they move around in another part of the lung. So that's the importance of mention and the management, that you need to check previous images to see if this is type eosinophilic type, which is the fleeting alveolar infiltration. Okay, let me show you something. Okay, so the most important to mention that, yes, fleeting alveolar infiltration, yes. Okay, let's go to the next case, which is neuro case. So our participants, Huda 130, Zoom user. Okay, there's some hidden names. What do you think about this brain, CT brain? And it is non-enhanced, no contrast in this CT brain. There is edema in the left side, okay, here, which is hypodense area. So hypodense density along the thalamus and the basal ganglia. Okay, I agree with you. So what else? So left thalami edema. Thank you, Dr. Moayed. So Dr. Moayed, you should, yeah, when you see anything in the thalamus, go directly and check the internal cerebral vein. And I told you that non-enhanced, so take care that here is hyperdense. So hyperdense internal cerebral and the hyperdense straight sinus. So dense appearance of the straight sinus, keeping with thrombosis, and you can note that there is also left thalamus hypodensity. That's nice. So what do you think about this appearance in the MRI? This patient did MRI, and you can see in this selected image how we describe blooming artifact. So this means that there is hemosiderin deposition in the left thalamus. So maybe there is hemorrhage before, and there is no surrounding edema. There is no significant edema. So again, you can see that there is might be abnormal signal in the straight sinus. But if you check, I think you like to check the sagittal image or the MRV of this patient. So the sagittal image, which is T1 signal. So the T1 signal here, you can see that there is T1 high signal, exactly. And there is T1 high signal along the straight sinus and the vein of Galen. So this proves for you that there is thrombosis. So straight sinus thrombosis. And now time to do MRV. This patient did MRV, and you can see that the straight sinus is absent. Also the infused sagittal sinus and the straight sinus is absent in its place, presumed place. Hiba? Yes. This one it was T1 and this one MRV. Yeah. So Huda, perfect. مؤيد. So we check for the internal cerebral vein, we check for the venous sinuses, and we find here that the straight sinus is thrombosed. The further management, in this case, they will ask you about further management. Already you see it is the MRV, and sure that you need to make referral to the specialist, and he will receive anticoagulant treatment. Yes. Let's go to this case, and pediatric patient. I know that pediatric is not but we can try. Not easy, but we can try. Chest radiograph in different views. Yeah, you can see that there is something abnormal in the ribs. I see, yeah, especially the posterior ribs. So you can say that is it like something related to the rickets or maybe fractures? Yes, Abbas. So maybe fractures exactly. And the posterior ribs is characteristic for something called non-accidental injury. So if in this patient, I think you are going to check if this patient did skeletal survey. Yeah, non-accidental injury or what is called child abuse. So there is multiple rib fractures. So you can see that there is multiple rib fractures in the posterior aspect. Also, if you check for the clavicle, I think here you can see that the clavicle look like there is also fracture there. So it's not always to be like rickets. It can be fracture. And then is importance to check other bones. They like to ask you in the MCQ about the specific sites of the non-accidental injury. So in this picture, what exactly you are going to search for? Yeah, metaphyseal corner fractures. So you will search for metaphyseal corner fractures. To check if there is any femoral or tibial fractures, and the same in the fibula and so on. Okay, the specific sites of non-accidental injury. The presence of asymmetrical fracture, especially in the ribs, and the metaphyseal fractures, very strong suggestion of non-accidental injury. It's very important in the exams, all exams. So you are going to check these sites. The differential diagnosis, it will be, as you mentioned, rickets or osteogenesis imperfecta. So when you find multiple fractures or you suspect fracture with different ages in patient, you will think as non-accidental injury as first instant in the differential diagnosis. Then you are going to check if this patient have any other clinical data that could suggest that rickets on osteogenesis imperfecta or something called metaphyseal dysplasia. So again and again, you check for all the bones, which is called skeletal survey. So you will go to do for radiographic skeletal survey, and sometimes, and now, sorry, not sometimes, now they also include CT brain to check for any accidental, non-accidental injury. Okay. You remember that the osteogenesis imperfecta as a differential diagnosis typically take the long bones, the shaft of the femur, for example, and associated with minor trauma. So the history is important. And also there is what is called Wormian bones and reduced the bone density. In the rickets, you know, in rickets, always have what's called metaphyseal cupping, fraying, and so on. I think if you go to check the skeletal survey, you'll find easy the metaphyseal corner fractures, which is a specific or highly specific or highly suggestive of non-accidental injury. Again, pediatric patient, pediatric age group, another case. Okay. So this patient did this plain X-ray of the abdomen. So what do you think? Persistent pain and vomiting. Yes, double bubble sign is easy one. So double bubble sign indicative that this patient have duodenal atresia. So gaseous tension of the stomach and the first part of the duodenum. So double bubble sign is important when you describe this X-ray to mention in your report that there is no free air. Yes, so you can take the full mark. And also to comment about the distribution of the gases either in the small bowel or large bowel. So you can see that there is no evidence of gas distally in the small or large bowel. So then you can take the full mark, even if you know the diagnosis. But if you didn't mention these two important comments, you will lose much. Okay. So differential diagnosis in this case will be duodenal web or duodenal stenosis, which is have similar picture, but usually they associated with gases in the distal bowel. That's why it's important to mention in the description. Also, you can mention, as Hiba told us now, annular pancreas, which is compression from outside, like annular pancreas or something like duplication cyst that make compression above outside the lumen of the duodenum. Then you can see the same appearance with proximal dilatation of the stomach and the duodenum. The further management in this case, if they ask you about this, it will be contrast study, upper GI contrast study to confirm the diagnosis, and urgent referral to pediatric surgery. You need in this patient to check other associated congenital anomalies. They like to ask you in the MCQ about this. So the most important congenital anomaly will be, Dr. Rasha, can you close the video, please? So the most important associated congenital anomaly will be Down syndrome. Exactly, Huda. Thank you. Down syndrome and duodenal atresia, D with D. Okay. The importance of upper GI contrast study is important to differentiate from other causes of obstruction. We mentioned this before, if you remember. Let's go to this case, which is selected images of CT of this patient. How to describe it? Maybe you can start with, there is pleural effusion, pericardial effusion, and bibasal lung atelectasis, and exactly rib fracture, Huda. Thank you. So there is rib fracture. Then now maybe you think about trauma. So you will ask in the history if there is any trauma and check if there's any other images. So what do you think about this? We have a lot of participants. If you can, yes, try to share with join us in the discussion. This liver laceration, yes, so you describe it as low attenuation area extending until the liver surface and extending to the hilum of the liver. So this is what is called liver laceration. You will try to trace if there is any fluid in the pouches of the abdomen, and you will check the spleen if this is intact or not, and the kidneys, and there is any excretion, abnormal excretion in the kidneys. The patient already, you can see that there is nasogastric tube and there is drain here. And again, is important to mention that there is no free air. I think if you didn't mention this in this case, you will lose much marks. Even if you describe everything is fine, but you should mention that there is no pneumoperitoneum, intraperitoneal gas. So liver laceration, secondary trauma, right pericardial effusion, and there is rib fractures. So this patient need emergency transfer to liver unit and need CT to see the liver necrosis and if this patient will develop any sepsis or not. Okay, so this is trauma patient. Let's shift to this case, which thyroid ultrasound. And this patient did ultrasound and thyroid, and he have this appearance. So our expert in the ultrasound, how we describe it? Yeah, there is a suspicious nodule in the thyroid. I think just we take this case before, so maybe I will exclude it from the yes. Just I will skip it. Sorry. I think we showed it last time. Let's check this image, which is an easy case. So based in the liver cirrhosis picture and ascites, the probability of presence of this focal lesion, yes, that to be HSC, it will be the first possibility. Just to check the images, you need to mention in your report about the collaterals. Is important to mention about the collaterals because after that he will need GI referral and maybe endoscopic sclerotherapy or whatever, and also referral to the intervention, either embolization of HSC if there is no contraindication, and regarding the portal hypertension for tips, so referral to the hepatobiliary MDT, and yeah, so this patient have ascites, liver cirrhosis, and focal lesion. You remember when we talked that if there is any background of liver cirrhosis, there is focal lesion in the liver, so it will It will be HC until proved otherwise. So liver cirrhosis with hepatic focal lesion, HC will be the first possibility until proved otherwise. And it's important to mention that this patient have ascites or not, to be he is compensated or not, complicated or not. And what do you think about this one? After 10 months, this patient did this CT. So what do you think? Yeah, Nermeen, welcome. So after this patient, you saw it before, the liver cirrhosis, and now you see the lesion, how it changed. So what happened here, how you describe it? You describe it as fat-containing lesion. Yes. And also in the hypervascularity, it doesn't show like much hypervascularity like before. Yeah, that's why I told you that even with the liver cirrhosis, the best differential diagnosis to put, it will be again HC, because there is category called fat-containing hepatocellular carcinoma. So even if it have fat component, so again it will be hepatocellular carcinoma. So you will not change any differential. You will put your differential of HSC as a first possibility. So again, the patient have background of cirrhosis. So it will be hepatocellular carcinoma anyway. Just maybe you need to explain why this patient have this type of fatty degeneration, which is not very typical in these cases. Do you have any explanation for this? Yes. So this what you can just think about other types of cirrhosis, that it is not always this typical type of cirrhosis that you see, especially in Egypt. There is another type of cirrhosis that can happen. Yeah. So with which type of cirrhosis that you expect to show this fatty degeneration? So it will be secondary. Yes, Rabab, thank you. You come in time. So this, it could be alcoholic. Yeah, alcoholism. Yeah. So always we see the chronic viral hepatitis, but there is maybe sometimes other type of causes that show you the cirrhosis here. So maybe there is other, you know, that there is other carcinogenic like Wilson, hemochromatosis, alpha-1 antitrypsin, and so on. But alcoholism is one of them. So you can think about it. And I know that's not typical case, but you have rules. With liver cirrhosis, HSC will be the best and typical differential diagnosis until proved otherwise. Fatty changes can happen, as Nirmin told us, in 30% of cases. So we have this type of HSC. It's important to comment about the portal vein. There is any vascular invasion, and also in the hepatic artery. And if there is any change in the ascites, I see one of good comments about the density of ascites, because if this patient have HC and it have rupture, then the density of the ascites will be high. So also you should comment about this in your report and in the exam. You know that the treatment of HC in the interventional will be radiofrequency ablation, TACE, intra-arterial chemoembolization, and maybe surgical resection. Let's try now some quick short cases. I wish that you can, inshallah, it will be more easy. I hope so. So in short cases, maybe it will be just one question or few questions. And anyway, we take it like a spot short description. So what do you think about this case? Who will be our star today? The first big star, take the first flower. We'll send him a special flower. Try to find the in checklist. Maybe we can just try to remember the checklist. So sure that the first thing in the checklist you will check for the lungs, and try to find the hidden areas, and then you check for pneumothorax and any pneumo down, pneumo up, whatever, any air in the image, and they check for the pleural effusion, and you take the the mid axis of the chest. The connection is fine, or I lost? Okay. So you'll activate your checklist, check for costophrenic angles, yeah, and so on. So nice. So Dr. Abbas will be our big star, first star today. Yeah. So we check for posterior lesion in the rib. Are you sure in the rib? You are very near, but it's not in the rib. Posterior, yeah, I agree with posterior, but which posterior what? So check for the lines of the mediastinum. If you remember, posterior and anterior junctional line, paraspinal lines, paratracheal lines. You remember? Ah, perfect, Huda. So which paravertebral line, paraspinal, which one is affected? Yeah, both and more on the right side. That's good. So this it give you indication that there is it anterior mediastinal, middle mediastinum, or posterior mediastinum. So posterior mediastinal mass, exactly. So the differential diagnosis in this case will be paraspinal lesion, maybe nerve neurogenic tumor, nerve sheath tumor, for example, and what else? And extramedullary okay. I think the sound now come back. Sorry, there is connection error. We're talking about the differential diagnosis of posterior mediastinal mass, and we talked that it is posterior mediastinal lesion, so you will need CT anyway in the investigation to see the, and maybe MRI spine if you suspect, and maybe biopsy if you need to confirm what it could be. Let's go to the second case. Is easy case. Yes, very easy. Unicameral bone cyst, single bone cyst with bone fragment. Okay. This one, what do you think about this one? Very difficult case. Not very difficult, but okay. You would check for pneumothorax. I agree with you. But if you go to the abdomen, do you see any abnormality here in the abdomen? Calcification along the side of pancreas. So it will be chronic pancreatitis. Yes, chronic pancreatitis. Very difficult, I know. But they like it in the exam. Maybe now is more Obvious, okay. What do you think about this one? Yes, malignant looking lesion with periostea reaction that look like malignant periostea reaction, aggressive bone lesion. Yeah, osteosarcoma will be top of this differential diagnosis. I agree with you. Let's see this case. Selected images of CT. This patient in prone position have shortness of breath, so there is some changes by basal, and if you check them in the supine, this is changes you can say that ground glass, reticular changes, and some interstitial thickening. There is no effusion and there is no cardiomegaly. If we go to the prone position, they are persistent in the lung basis. So this interstitial infiltrate with ground glass and septal thickening, subpleural mounting to honeycombing. So it could be UIP, usual interstitial pneumonia. I agree with you. What other differential you can put? Sarcoidosis, maybe, but you need to have typical appearance of sarcoidosis, even distribution of nodules, which is not in this case. Maybe non-specific interstitial pneumonia, but again, there is subpleural sparing and there is some interstitial changes that a bit far from this case, but you can put it in the differential diagnosis. So don't forget the entity of connective tissue diseases like rheumatoid and scleroderma, especially if when you check to this patient, you check and you find that he did X-ray for his hand before, and this is the appearance of his hand. So now what it could be, check for the Yes, exactly, Hassan. Thank you. Our big star today. There is tuft resorption, and so this patient could be scleroderma. The thing that you will check again for when you go to the CT, you will check for the image of the esophagus if it is present, to check for any esophageal dilatation. They like it in the exam, in the MCQ, and everything. Picture of scleroderma, persistent interstitial changes by basal in lower lobes. So scleroderma is the best thing for this, especially with tuft resorption. The selected images of head and neck in this case, let's take it as a last case in this night. What do you think about this patient? How to describe it? So there is bony affection, destruction, displacement of the posterior maxillary sinus or antrum wall, and what else? I want you to mention something which is very important in the description. If you are in the long exam or even in Viva, or that you should comment in the case of you'll put even differential diagnosis. As I see, you will put angiofibroma or aggressive bony lesion. So sure that you need to describe it as the first thing in the report. Yeah, this is the pterygopalatine fossa. So the pterygopalatine fossa and pterygopalatine fissure. You will mention that this lesion is centered upon the pterygopalatine, and there is destruction of the pterygoid bone and expanding to the right pterygopalatine fossa. So juvenile angiofibroma, it will be sure one of them. Yes. Pterygopalatine, Abbas, Huda, perfect. I agree with you. This patient did MRI. You can see in the T1 how it look, and the T2, sorry, look like T1 again. So in T1 is low signal, and T1 with contrast, you can see how to take post contrast enhancement, intense enhancement, and you can note, yes, vivid enhancement, Huda, perfect. And you can note this low signal inside the lesion, which indicate that it could be flow voids. Yes, flow voids. So juvenile angiofibroma, it could be one of them, the best differential diagnosis in this case. MDT referral, and maybe this patient need embolization prior to surgery. So this will be the management. And biopsy, no biopsy is contraindicated in this patient. The most important to know that this patient is male and young age. Yeah. Local invasive tumor. That's why when you describe it, you will mention destruction in the bone, invasion to the pterygopalatine, infratemporal fossa, maxillary sinus, and so on. Maybe it can reach the orbit. Everything you should comment. No calcification. And in the management, preoperative embolization. I wish you enjoyed this collection today. I hope that these technical errors will not recur again. And inshallah, see you inshallah soon. Assalamu alaikum.